Welcome back to Parkinson's WA's Awareness Month, which is April, and we are presenting short information sessions, which I am very pleased and proud to be able to represent Parkinson's WA. For those of you who don't know me, my name is Janet McLeod, and I have been working with Parkinson's WA since 1998, and I'm currently the clinical nurse manager. So, we've already discussed in other sessions what is Parkinson's and an introduction to the condition, and I've done one session that touched on levodopa for a very brief overview. Today I'd like to go away from the condition itself a little bit and go away from the medications and discuss something that's really important to all of us, but even more so for people with Parkinson's, and that is sleep and sleep disturbances in Parkinson's. So I hope you're wide awake and got a coffee and you can manage to stay with me through this sleepy presentation. So a little bit of definition, just as a recap. Parkinson's is a neurological condition primarily due to a lack of dopamine, and it results in a plethora of symptoms, mostly classified as movement symptoms, but you know, the longer we've had effective treatment for the motor or movement aspect of Parkinson's, the more the non-motor symptoms and problems have risen to the core. And also things like sleep disturbances are now a severe problem for many people with Parkinson's. And what is sleep? Sleep is defined as a bodily condition which normally occurs for several hours, and hopefully more than several, every night. And it is during our sleep that our nervous system is completely rested, our eyes are closed, our muscles are relaxed, and our conscience is nearly suspended. We know that sleep is a time for our brain to recover and recuperate, and we are now becoming more and more aware of new theories as to how important sleep is. Interestingly enough, even though it is a movement disorder, sleep affects Parkinson's and the manifestation of the condition from a very early stage. This stage is called prodromal, so it is before the diagnosis and before the movement symptoms become apparent. Something is going on in the brain which will disturb the sleep pattern. In my first talk, I talked about the Parkinson's Associated Risk Syndrome, or PARS, and this has identified that sleep is a big part of the pre-motor symptom manifestation of Parkinson's. The other PARS include anosmia, loss of sense of smell, which happens at about 90% of people, apathy, lack of motivation, and depression, and constipation. But I'm sure many of you listening in or watching in today will be able to recall the way sleep was impacted for many years prior to your diagnosis. What are the sleep problems? Well, we're all a bit like Goldilocks. We want to get it just right. But unfortunately, in Parkinson's, the problems are split up into too little sleep, too much sleep, and we can get to sleep, but it may be disturbed or broken. And all of these sleep problems, whether it's too little or too much, can impact on quality of life. And they impact on quality of life not just for you, the person with the Parkinson's, but also for your bed partner or your partner in life. And as a nurse, I'm very aware and being privileged to be privy to the number of times that bed partners have decided to go to different beds or to different rooms due to these problems related to their Parkinson's. So wouldn't it be wonderful if we could all be like Goldilocks and get it just right? So early Parkinson's, as I said a few minutes ago, we know that sleep disturbances often precede the other Parkinson's symptoms. And there was a huge study done in 1986 that described these sleep problems. And we know that dreams are acted out. Now, normally when one is sleeping, the body is totally relaxed and you shouldn't be moving apart from normal bed mobility. But in rapid eye movement disorder or sleep disorders, these dreams can be acted out quite violently. We know from this study that 87% of the people who were acting out their dreams in this study were males. So it happens more frequently in males than females. But having said that, Parkinson's is slightly more common in males than females. A sad outcome of this study was that 64% of people experiencing the sleep disturbances actually assaulted their partners. And this is not something to be ashamed of. This is something that needs to be discussed. And I myself have heard many stories of quite active assaults which have happened quite inadvertently and through no fault of the person who is dreaming or acting out their dreams. So as a result of that, quite a lot of injuries were sustained. One of the other aspects of Parkinson's medication is that levodopa and the other Parkinson's medication may actually address this symptom of the condition. But if it doesn't, other medications can be prescribed by your neurologist or your geriatrician, which will help. So for this reason, it's important that you discuss this aspect of your life. You know, it is very important if the doctor doesn't ask you how you're sleeping, that you bring up the topic, because this is not just about you, it's about your partner, and it's definitely about quality of life. So that is just before diagnosis. So as Parkinson's progresses, we know that the numbers of people with impact on their sleep pattern will steadily increase. And we know that on an average, 98% of people will have sleep disturbances in some way. Not necessarily the dramatic acting out and injury to a partner that I discussed before, but I'm going to go through them. So these disturbances may be related to the Parkinson's, or they may be related to the treatment, or they may come from left field, because let's face it, even without Parkinson's, people can have broken sleep from time to time. One of the plus signs, there are not many positive things that we can discuss in a topic like this, but one of the positives is that some people, a small minority, but nevertheless some people, may actually wake up in the morning and be aware that their Parkinson's symptoms are not as the same level as they are normally. This is known as the sleep benefit. And this group of people may even postpone, with their doctor's permission, postpone taking their first Parkinson's meds until they're aware of the need to it. So talk to your doctor if you are experiencing the sleep benefit. You may just wake up thinking, gosh, I feel good, I'm not slow, I'm not stiff, I'm not rigid. We feel that this may be due to something that's happening during the sleep process that is enhancing the levodopa or the dopamine. So people may not be waking up waiting for their first medication of the day. So at least that's a positive. So after sleep, mobility may have improved. And then as the morning progresses, the need for medication becomes apparent. What are the sleep problems or sleep disturbances that are associated with Parkinson's? One of the interesting things in Parkinson's is that most people do not have a problem getting to sleep. They go to sleep very quickly, so there's no sleep latency. But what they do have is broken sleep or sleep fragmentation. So they wake up during the night several times. So people may go to bed and fall asleep very, very quickly, or in fact may even be asleep on the settee before they go to bed. but then they wake up during the night and are unable to settle again. And this is really common. It affects high numbers of people, perhaps 45, even as high as 90% of people with Parkinson's. It may be due to a breakthrough of the Parkinson's symptoms, because it's a general rule of thumb that we do not take levodopa or Parkinson's medications overnight. You may find you're taking medication 4 hours, for every 4 hours during the day, but hey, at overnight you have that long gap between going to bed, let's say at 10, and starting again at 6 o'clock in the morning. So it may be that when you do wake up, you're aware of increased stiffness or rigidity, or perhaps your tremor has broken through. It may also be what we call dystonia or cramps. Dystonia is experienced often in the legs or in the toes, but at night often in the lower limbs, where the foot or the leg might go into a cramping, and it may be associated with an abnormal posturing. For example, toes may curl up towards the ceiling or cramp back down towards the mattress. And this is something that if you are experiencing it, you should discuss with your medical specialist. It may also be that it's simply a question of bed mobility problems. So it's not actually the Parkinson's symptoms breaking through, but it's the fact that the ability to roll over in bed may be affected. Now, one of the interesting things about Parkinson's is that it affects the automatic skills. All those skills we learnt as babies and children. We laid them down in our brain and we fire them up automatically. So tossing and turning, rolling over in bed is a very automatic skill. You may remember that when your grandchildren learnt to roll over in the bassinet or in the cot, everyone got excited. And we continue to do that throughout life. But unfortunately, in Parkinson's, the ability to initiate those automatic movements often gets affected. So it may be just a bed mobility problem, the ability to turn over because one is stiff and rigid. So we nurses often talk about the advantages of satin nightwear or satin sheets. And in fact, here at the Parkinson's Association, we sell and supply sheets with a satin insert which goes about the trunk. So that enables a bit of slipperability and the ability to move from side to side and overcome that bed mobility problem. Also, especially in years gone by, we used to recommend things like bedside rails. They're not so popular nowadays, but I know the occupational therapist, if you have access to one or if you attend a clinic, talk to the occupational therapist about the availability of aids and equipment to help with rolling over in bed. And the other thing is then, if you are waking up at night and you're not able to settle again, one of my favorite questions is, so what are you doing when you're awake? Because one of the side effects of the Parkinson's medication may be pleasure-seeking behavior. So it's not uncommon to hear of people being awake and going to the fridge, going to the freezer, eating ice cream, eating chocolate, which is a very rewarding feeling, and it's driven by the Parkinson's medication. Or, for example, getting on the iPhone or getting on the iPad and exploring gambling options, or even more pornography or things like that. So please be aware, these are side effects, this drive to explore these pleasure-seeking things. These are a side effect of some of the Parkinson's medications. And it's often when people are awake at night that they explore these activities. And it's really, really important that these are discussed either with the nurse or with your consultant, because they can be modified. And it's important that people know about this. So when you are awake, If you are awake, why do you think it's happening, and what exactly are you doing? And of course, I'm just talking about Parkinson's now. I'm not talking about general sleep hygiene. You should have your iPhone or your iPad or your laptop well away from you, ideally not in the room overnight, to avoid that stimulation and that light that we know is so bad for our sleep pattern. But related to Parkinson's, try and find out, just quiz yourself, what may be the cause? Why am I waking up? And then talk to your health professional about that. Other causes of sleep problems, very, very common ones, restless leg syndrome. Restless leg is very common in the general population, but people with Parkinson's also will experience it. Now, some of the Parkinson's medications, particularly the dopamine agonists, are very good at addressing restless legs. So it's important, if you experience this, then to talk to your specialist about it, because there may be a treatment option that will help. Another aspect of nighttime for all of us, but particularly with Parkinson's, is nocturia. We often get the urge to pass urine during the night, and this is particularly becomes more evident as we get older. When we lie down, when we're older, the blood supply to our kidneys is enriched, and this is making more urine to be passed. So this is again something to be addressed. Talk to a continence nurse advisor or talk to your specialist about this. Depression has a particular sleep pattern affiliation, in that people with depression will often waken up during the night wide awake and are unable to settle again. So when we nurses see you, or when you visit your geriatrician, we will carry out a little screening tool for depression to give us a feel for how your mood is, and this may indicate that your depression or your mood changes may be the cause in some part of your sleep fragmentation. Doctors are now exploring obstructive sleep apnea. This is becoming increasingly common, it seems, in the population, and people are often referred off for sleep studies, and the use of a CPAP machine will help rectify this. It's more common in males than females, and it's more common in people who might be a little bit overweight or carrying a lot of extra flesh around the throat area. And it quite can be dangerous, so it is not something to be brushed aside. If someone asks or suggests that you go for a sleep study, I would certainly recommend it. And we do know that sleep apnea is becoming more linked to neurological conditions the more research is done for them. And the treatment options are varied, and I believe CPAP machines are improving in their user friendliness all the time. Now, daytime sleepiness. We're all familiar with the wiggles, and often I'm sure the partners of people with Parkinson's can relate to, they want to call out, "Wake up, Jeff," because daytime sleepiness is very common in Parkinson's. We have fancy words for it, of course, as we always do: excessive daytime somnolence. So this is where Parkinson's sleep can be too much. You remember Goldilocks? We had too little and too much. So daytime sleepiness comes into the too much category. It's often related to the Parkinson's medication. So if you start on a new medication, it's important, if daytime sleepiness is experienced or observed by your partner, then it should be reported to the doctor, particularly if it is excessive. And it's in this area that driving can be an issue. One of the families of drugs has got a particular red flag attached to it with regard to sudden onset sleepiness. It seems to be in my experience, less of a problem than the literature might suggest, but nevertheless, one does not want to be running the risk of driving when sudden onset sleep can be an issue. Daytime sleepiness can also be involved or due to other things, such as poor sleep hygiene or depression, but it can also be related to the progression of the condition. We often find that the longer a person has Parkinson's, the more time during the day is experienced in extended napping. And there's a very fine line in knowing what to do, whether to wake someone up or to let them sleep. So this is something that partners often discuss in depth with doctors and with nurses and health professionals in general. So it's important to know it may be related to the condition and it may be related to the medication. Sleep changes that are related to medication may be dreams. As I said before, dreams are often a symptom of the condition, but also maybe a side effect of the medication. And also, particularly as one gets older, and the more medication people are on, the doctor may decide to bring the timing of the last Parkinson's medication earlier in the day to try and address those vivid dreams, and particularly if they're frightening. When people answer our question about how are your dreams, often they will say, don't worry, they're fine and we can leave them. But if they're frightening, vivid dreams or nightmares, then that is something that can be addressed. So please don't feel that there is nothing you can do about these. They must be discussed with your doctor and your health professional. Some people even experience what we call parasomal experiences or hallucinations. So someone may have a dream that extends into the wakening hours. So when they waken, they're really not sure if it is real or not. And again, that's a typical Parkinson's thing and should be discussed with your health professional. Now, if people are not sleeping or having that sleep fragmentation that we discussed a few minutes ago, there always is that tendency to rush to the GP for a sleeping tablet. And thankfully, sleeping medication seems to be used less and less as our treatment and management of Parkinson's becomes more and more refined. My advice on sleeping medications is be very, very cautious. Sleeping medication may certainly help you sleep and get an extra hour or so overnight, but it can be a double-edged sword. Parkinson's sleeping medications may actually cause drowsiness the next morning, may cause confusion, and may cause drowsiness and relaxation to the point where you may find yourself falling or stumbling a lot in the morning. So if you can avoid sleeping medications, certainly try to do so. And there are many more natural forms of sleeping medication available nowadays and being used a lot by doctors than we had in the dim old days when I started my nursing career. So as a little overview, I'd like to just encourage you to think about your sleep pattern and realize that sleep problems in Parkinson's are very, very common, and you should be discussing them with your neurologist, and they can be due to the condition and they can be due to the treatment. So it's important to find out just exactly what's happening. They can be physically caused or they can be caused by our psychological state of mind. So depression may have an impact on your sleep pattern, and it may be that you've got broken sleep at night and excessive sleepiness during the day. Don't ever forget the normal sleep hygiene rules. So avoid caffeine before going to bed, avoid caffeine in the evening, avoid alcohol in the evening, because while it may initially get you to sleep, we know that alcohol can lead to broken sleep. Avoid having your electronic equipment in the bedroom with you, and generally study up on sleep hygiene and become an expert in that field yourself. But certainly always talk to your doctor or your Parkinson's nurse specialist about your sleep, because if you don't get a good sleep at night, I can guarantee you probably won't have a good day the next day. So I'd just like to thank you for listening, and now you can wake up Jeff.